Maybe let's dive in a little bit deeper into the provider experience and talk about that. That's kind of what we want our first conversation to be about. And then we'll be talking more about patients a little bit later. But just for some further introduction, just to kick us off, we're going to have Dr. Matt Bouchonville give us a little bit of a talk about Project ECHO and the role a model like Project ECHO can play in all of this. Dr. Bouchonville is an associate professor at the University of New Mexico School of Medicine in the Division of Endocrinology, Diabetes, and Metabolism, and serves as medical director of the UNM Diabetes Comprehensive Care Center and the UNM Center for Diabetes and Nutrition Education, and the Endocrinology Tele-ECHO and the EndoEcho program at the Endo Institute. So yeah, a lot of insights from Project ECHO and from kind of the beyond the oncology space as well. So I think lots for us to learn. Here you go.
All right, thank you. So I'm Matt Bouchonville, and do I just hit this arrow to advance? Great. And I'll be talking to you about a different way of practicing healthcare. It's called Project ECHO, and yeah, I'll specifically be speaking to the provider experience. No conflicts of interest. And just for a brief background, I want to show a picture of New Mexico here to make the point that it's a very large rural state, and that's part of the reason why Project ECHO was started in New Mexico to begin with. And what we're looking at here is actually a picture of Albuquerque at the base of the mountains. Albuquerque sits at about 5,000 feet, and then the Sandia Mountains sit about 5,000 feet above Albuquerque. And if there's any Breaking Bad fans in here, the images that might come to mind when you think of Albuquerque would be Winnebagos and chemistry. But as a healthcare provider, what comes to mind when I think of New Mexico is that it's a very medically underserved region. So HRSA has actually designated 30 of our 33 counties as being medically underserved. So access to care is a big problem in New Mexico. And so, in fact, when we were doing a needs assessment about 5 or 6 years ago from an endocrinology standpoint, we were looking at counties in New Mexico that actually had an endocrinologist in them. And really, it was just a handful of counties. And most of those were centered around the county in the middle there where UNM is. It's the referral center for the state. And in contrast, if we look at where just the type 1 diabetes, those are the autoimmune diabetes, referrals were coming from just over the course of a year. You can see they're really coming from all over the map. And the same is true of type 2 diabetes. And these are the patients who could actually afford to take a day off of work and travel 5 hours to get to UNM, 5 hours to get back, or come the day before and stay a night, you know. And you can imagine that we were pretty overwhelmed in the endocrinology clinic as a result of this. So for a new referral to the endocrinology clinic. And endocrinology, it's mostly diabetes. It's really a specialty of hormones, thyroid and so forth, mostly diabetes though. So for a new referral to the endocrinology clinic at this time, the wait time for a patient was about 13 months, so over a year for a patient to get in. And sadly, this is not a problem that's unique to New Mexico. So same kind of picture with endocrinology that Dr. Schwartzberg was sharing with us with respect to oncology. And so what does this mean for patients with complex diabetes on insulin pumps and so forth? It means that really the brunt of care is falling on the primary care workforce. And not all primary care providers feel equipped to manage complex diabetes or other endocrine conditions. So in this specific survey, PCP cited a lack of confidence or adequate training as being like barriers to providing optimal diabetes care. But PCPs also recognize that there's a major barrier to getting patients into an endocrinology clinic. So when asked about what a solution might be, they reported that case coaching and a multidisciplinary collaboration could potentially overcome these barriers. And that's a very important point to make there because that's essentially what Project ECHO is. So I mentioned during the introductions that it's really a telementoring program. And so if you think about, and we just heard a great presentation on all the different forms of telehealth, but this is just the traditional kind of telemedicine model that we think of. It's a very effective means for bridging a geographic barrier and has been very effective in diabetes in particular. What ECHO does though is kind of expand on this fundamental unit. So in the traditional telemedicine model, there's a specialist connecting with a patient remotely, but her wait list continues to grow. She's got a 13-month wait list to get into her clinic. So it's not necessarily capacity building while it does bridge geographic barriers. So what the ECHO model does is it's kind of a workforce development model. So you're actually building new expertise, building new capacity. It's a telementoring program. So on one end, you've got a team of specialists, and on the other end, there's not patients that are tuning in. It's actually primary care providers and other healthcare professionals. And they're meeting, this is a kind of an ongoing mentorship. I'm going to show you a picture on the next slide, but they're meeting regularly in these like virtual kind of clinic spaces via video conferencing technology. And over time, and I'll show you what this looks like, new expertise is being built in the primary care workforce so that more providers are able to do more for more patients. They're the end beneficiary. So it's really a force multiplier effect. And so here's what one of these sessions look like. We call these echo sessions or tele-echo sessions. So they're really like a virtual clinic. So and we use Zoom technology. And so on the right side, we've got a team of specialists at Project ECHO. They don't even necessarily need to be in the same room together. We could have people tuning in from different parts of the country or from their office at the hospital, wherever. But if you think about a hub and spoke kind of model, at the hub on the right there, you've got a team of specialists. And then the spokes of this hub and spoke model would be the people tuning in from medically underserved communities. In this case, these were mostly community health workers and primary care clinicians tuning in. This is actually our clinic. We call it EndoEcho. And ours is a weekly session from 12 to 2 every Wednesday. Some of these are every 2 weeks, depend on like other people's echoes. Some will have an echo maybe every once a month. And they're really framed around case-based learning. So the kind of learning that we use in residency programs and fellowship programs. It's a very engaging form of teaching. So essentially what happens is these clinicians on the network, and we can all see each other. It's kind of like Hollywood squares with all the tiles. It's very collaborative. So they will actually present a de-identified patient over the network. And then we'll do a round of clarifying questions. So their peers on the network will ask for clarification, we'll ask for clarification, and then we'll do a round of recommendations. And it always starts with their peers on the network, because over time they develop expertise and they're actually able to give recommendations themselves. That's really the bulk of the sessions. For about 15 minutes per session, we'll have a best practices didactic as well, so that we have kind of a formal curriculum. And those are really developed around clinical practice guidelines. So for our EndoEcho, that's usually going to be ADA guidelines or the ATA guidelines for thyroid, et cetera. And so that's what an echo session looks like. I mentioned that echo started in New Mexico. It actually started with hepatitis C treatment. And it was started by Dr. Sanjeev Arora. He's a gastroenterologist. And he published his experience in the New England Journal of Medicine, demonstrating kind of proof of concept that the model does work. It's safe, it's effective, and it's also very cost effective because you're not moving patients, you're moving knowledge. We call it a democratizing of knowledge. So as a result of this published experience, the ECHO model has really taken off. It's now all over the world. It's being applied to over 100 complex conditions and has been adopted by over 250 centers worldwide. And so all of these red circles here, these aren't the spokes, these are just the hubs. If you plotted the spokes on here too, it'd be even more widespread, as you can imagine. But the point I want to make here is that most of these are academic medical centers. Several of these are sponsored by an advocacy group. So American Academy of Pediatrics has their own ECHO, American Cancer Society. We are currently in talks with the American Diabetes Association to work on a collaborative ADA ECHO that will kind of work with us and then some of our partners that have replicated and started their own EndoEchos around the country. And some of these echoes, I bring this up because I think of immuno-oncology as being highly specialized, but some of these echoes, instead of the spokes being primary care clinicians, they're actually specialists And the hub is like a nationally recognized leader in the field who writes the guidelines. I think of Bone Health Echo, I participate in that one. And Mike Lewicki, who writes the osteoporosis guidelines, leads that echo. So some of these are kind of like super echoes that are building up the specialists. So you can kind of get the feel from this map that you can use the echo model to really rapidly disseminate best practices as new science emerges. And so how has our experience been? I'm going to speak more to the provider experience now in New Mexico with our Endo ECHO pilot program. So we just wrapped up a 4-year pilot program really aimed at improving capacity for care of patients with complex diabetes in New Mexico. And so we built recruited from UNM, essentially, a multidisciplinary team of experts. And so, again, just kind of emphasizing the team-based approach here. Everyone that we thought would be important to be involved in the care of a patient with diabetes who's being presented over the network. So a behavioral health specialist, endocrinology, educators, and so forth. And so that was the hub. And then at the spokes, we partnered with 10 federally qualified health centers around the state and identified a primary care clinician and a community health worker with interest in building up their expertise in complex diabetes management. And for the purposes of the study for this pilot program, we formally partnered with these centers, but echo sessions are free for anyone to tune into. So in addition to these people who were part of the study, and we were tracking like patient outcomes and so forth, we routinely have people just tuning in from anywhere in the state or the country that want to participate. And so, as I mentioned earlier, these sessions are really built around case presentations. And so the point of this slide is to show that most of the presentations that were presented over the 4-year program were really around diabetes care, type 2 diabetes and type 1 diabetes, followed by thyroid disorders as the second most common kind of condition, and then a number of other endocrine conditions that are encountered commonly in the primary care setting. And then I alluded to the fact that for a short set part of each session, there's a didactic, just so we can follow along a best practices curriculum as well. And this is just an example of what that looks like. We kind of broke it down into blocks. So like a motivational interviewing block, integrative medicine block, metabolic surgery block, etc. But really the sessions are built around case presentations more so than didactics. We want to get away from these turning into like a webinar. Just to keep it more engaging. All right, so what impact has this had on network participants? I'm on my last couple slides here. So, and specifically, I'm gonna speak to the primary care clinicians that we partnered with. So one thing that we found is that they were more confident after participating in ECHO. So self-efficacy improved significantly across the primary care providers that were involved in EndoEcho. They were also more likely to adopt best practices. For the purposes of this survey, we were looking at like ADA best practices. Again, making the point that ECHO is an effective way of disseminating best practices as new science emerges. We were really excited about this, that primary care clinicians participating in these weekly ECHO sessions were less likely to need to refer patients out to see a specialist. On the flip side of that, for the patients that these participating PCPs saw that they felt like really needed to see an endocrinologist urgently, they reported that access was drastically streamlined. And that, as an endocrinologist, that's a big benefit of the ECHO model, is that you could consider ECHO as a really efficient means of triaging a large geographic area and figuring out, kind of filtering out these patients that you probably need to see in your clinic within the next week or two from the really large base, actually, that can be appropriately managed collaboratively via the ECHO model. And then this was exciting too. These are PAs and nurse practitioners that we're building up through the ECHO model, and they're reporting that they're starting to get referrals from MDs in their community with complex diabetes and thyroid disorders, as if they're the local expert. And that's really the goal of ECHO, is to kind of set up these satellites around the state in these medically underserved regions. And so those are kind of the take-home points in terms of the provider experience. But just overall, in summary, with the ECHO model, we've built up our primary care workforce in New Mexico to treat complex diabetes and essentially empower them to treat patients who they previously would have referred out for care. So patients are now getting the care that they need in the communities where they live. And we believe that this is improving diabetes care in our state. And I do want to acknowledge the Helmsley Charitable Trust who supported this 4-year pilot program. And happy to take any questions. And my email's there too. If you wanted to reach out and like tune in for one of these sessions, I could send you a link, or you just have questions. But of course, happy to take any questions now too. Pass that down. Thank you.
I do have one, Matt. To what degree are you measuring, if you're transmitting knowledge of evidence-based practice or best practices, what part of the ECHO program actually can validate or observe whether or not that knowledge is being effectively transferred, other than just releasing it and seeing how outcomes change?
Yeah, thanks, Mark. That's a great question. So yeah, right. What I shared with you was self-efficacy, but didn't really speak to knowledge uptake. So one thing you can do is kind of look at the end product, look at patient outcomes, which we've done, and we're reporting those now. But specifically looking at knowledge, we did not do that. We tried to do this, but with ADA guidelines, they change every year, and actually a lot of the guidelines. And so it was difficult to come up with an assessment that wasn't kind of obsolete within a year. We do have partners at George Washington University who have developed a useful knowledge tool where they kind of got around that by giving kind of like patient scenarios. Part of the funding from the Helmsley Charitable Trust was really focused on developing resources to support replication of other EndoEchos. So now there's at least 10 of us nationwide. And so we're collaborating around shared metrics, around developing tools like that. So that's an area of great interest.
Great, thank you.
Thank you.
Matt, I have, this is great. I have one comment and one question. The question is, what is the inducement for the primary care physicians and providers, whether they're APPs or MDs, to stay engaged in this? I mean, it's a lot of time, and besides the satisfaction of increased knowledge and comfort in taking care of their patients, there are pressures to be there every week, and there's no necessarily reimbursement. So what's your persistence in this, and how many people do you have? Are you getting that's the question. The comment is that there's a very obvious analog in oncology for what you're doing, and it's the concept of tumor boards. So what we find is that, and I am, besides my role at West, I'm Chief Medical Officer of One Oncology, which is a network of community-based independent practices, and we're kind of struggling with this in a practice like Tennessee Oncology, one of our collaborators, where they have 32 sites, 90 physicians, and they each go to independent hospital-based tumor boards. We don't really get the wisdom of the entire group across, and this kind of platform would be fabulous for a disease-specific tumor board, which we have at West. We have, as an independent, a little unusual, we have 11 different tumor boards that we run, which are disease specific. But using this technology to really within the discipline, I mean, there's definitely an analog for disseminating to primary care, for example, on IO and toxicity. But there's a great need for those that work at satellite hospitals to get or clinics to get the expertise of the disease lead. And this looks to me like a great opportunity to do that. But I'm just concerned about how do you get people to participate long term?
That's a great question. Thank you. So it does sound like a great opportunity to me. Addressing the very last part of your question, how many people are usually tuning in for the sessions? The picture you saw was a pretty accurate representation. It's usually in the ballpark of 20 to 30. There's kind of a sweet spot. If it's too low, you're not going to get enough interaction. If it's too many, actually, you're not going to get enough interaction because people are almost afraid to speak up. Although there is a chat function. So when the group gets that big, people can kind of chat in, and then you can kind of call on them and facilitate engagement. But usually 20 to 30 different tiles tuning in is kind of the sweet spot. There are tricks to work around clinic. Some centers, we aren't doing this, but some centers are doing their echoes before 8 a.m. So like maybe starting at 7 o'clock, go from 7 to 8. We do ours over the lunch hour with hopes that people can get a lunch. Not everybody can. So sometimes people are tuning in about 15 minutes late by the time they wrap up their clinic, which is fine. But so those are some of the ways you can get around that. Leadership buy-in is probably the most important thing. And I think leadership, CMOs, et cetera, recognizing the value of echo so that there is some protected time for people to tune in, generally, again, over the lunch hour, because you don't want to cut into clinical revenue so much. The outside of that, there's CME awarded for clinicians that tune in, and I forget the analog for, in the pharmacy world and the nursing world, but those credits are provided each session. There are health plans that will reimburse primary care clinicians for presenting a de-identified patient over the network. So that's a big big deal right there. What are some other? Interestingly, echo has been, it's been shown to improve provider satisfaction and enhance provider retention. So healthcare centers are aware of that and have actually used echo not only as a retention tool, but even as a recruitment tool to bring clinicians in. So there are a lot of perks, but yeah, there's definitely that real balance that you bring up. You don't want to cut into clinical revenue. So making sure that you're being practical with the time that you're scheduling your virtual sessions is really important. Thank you.
A comment that I found was really interesting in your presentation. As we talked about the provider shortage that's coming down the pipeline or here, one thing I thought was really interesting was the utilization of Project ECHO with PAs and NPs. From a PA perspective, our education is primary care. So when we're coming into the hem-onc world, there's a huge learning curve. We don't go through that fellowship. So I can see how this would be directly translatable to PAs and NPs coming into the hem-onc world and going through these case-based scenarios, talking through the process, even the small didactic portion. You could really build a strong APP group within your organization or even within the community to be able to provide IO and any sort of cancer care, really.
Thank you, Sarah. Great. I'm glad you brought that up. We actually, this is an idea we stole from George Washington University too. The endocrinologists there for their EndoEcho partnered with their PA program. And so we've done the same. So the leadership of the PA program at UNM has kind of worked into the curriculum, the PA curriculum, that they have to attend so many echoes. It doesn't have to be an EndoEcho. It could be GI's echo or rheumatology's echo. So that by the time they're out in the field working, they're already kind of comfortable with using the echo model. But another kind of what you were just alluding to, thing that we've seen that's really exciting is that 2 or 3 of the nurse practitioners and PAs that were part of the 10 and the FQHCs that I pointed out have, as a result of participating in EndoEcho over a few years, they've been picked up by endocrinology clinics like in different states. But I agree with you, there's not really a formal training program per se for them outside of the primary care world. So this is another application of the ECHO model.
One thing I would add, I extracted quotations from a number of you that were really potent, all of you. One thing that Gary said that really struck home is, I'm only as good as the nurses I work with. And in this new world, which you're certainly involved in, Sarah, where APNs or PAs are with the patient at the remote site, they are the critical eyes and ears and hands for that remote physician. And to the degree that they have this robust skill set and understanding of not only insights in IO and oncology, but also insights onto how to use the telehealth technology to better affect communication with the supervising physician is really powerful. And this really is a kind of golden era for APNs and nursing assistants who are now being, in certain states, 19, reimbursed as PCPs actually, because there's such a shortage of care, and they're doing it via telemedicine.
I have another point as well. As I'm looking at this, looking futuristically, and there's some movement in bringing patients into tumor boards and having them see their care team discuss. That would be an awesome application of some sort for a patient to be part of their care team and hear them all talking about their case. I thought that would be an interesting way to take it to the next level.
Yeah, that is very interesting. I'm not aware of any echoes that are bringing in the patient that's being presented. Thus far, there hasn't been a direct patient-provider relationship. And so part of that is why there haven't been any medical legal concerns, because you're really consulting kind of, it's really a mentorship. But there are a couple echoes that are bringing in a patient as kind of a peer representative. Maybe their case isn't being presented, but they're giving the patient perspective. And I think that would be so helpful, especially in the diabetes world. Well, you could imagine for any community, medical community. So that's an interesting thought for sure. Thanks.
So one thing, when we're talking about this, I find it very interesting because with immuno-oncology, we often find a lot of endocrine side effects, right? This is a very common theme. It was actually underreported with the first IPI studies. It was 0% hypothyroidism in the initial, because they weren't testing for it because it was unknown, right? And that was a big issue. We have a lot of unknowns with CAR T, with BICMA therapy. So we're in this virgin discussion of how to follow up as well as how to treat. One of the things that I do find of interest, Matt, with your endo group and also with endocrinology-based focus here, whether diabetes, whether thyroid dysfunction, whether HPA axis dysfunction as well, is that with our immuno-oncology agents, whether in a single monotherapy treatment or in combination, we often find that even though our oncology team is treating the patient with these therapies, we are now actually relating these patients or actually referring these patients to endocrinologists for hypothyroidism, for diabetes, dermatologists for actual treatment of skin conditions or rash, just to kind of give you an example, or even our pulmonologist if there's a pneumonitis issue. So one thing to kind of bring up with the ECHO discussion and see if there's a follow-up on this is we are seeing when a patient goes in, they're actually on immunotherapy, we'll say for melanoma. In Arizona, we almost have no sun, so it's very rare. But one of the key conditions, just like in Albuquerque, one of the key conditions is we do have patients every once in a while who will be seen by their PCP and they'll get their thyroid check. What happens? Your hyperthyroidism. And so they'll actually treat with IMID and methimazole in these cases. And what will automatically happen is, no, don't treat the patient, let them burn out their thyroid and go to hypo. So going to really Una's point, really in this overall discussion and even relation to Sarah's points on education and other pieces, the question is, have you looked at this from an interdisciplinary review of the patient? So, for example, patients in 100, 200 miles away, you have your oncologists, you have your endocrinologist, maybe a dermatologist. Has that been ever discussed? Because for the immuno-oncology situation, when we're dealing with patients, it's not often dealing with the treatment therapies, it's dealing with the side effect management. And I think from that perspective, that allows us to say everyone's on the same path, just like with tumor board, how we're treating, what's the pathology, what's the disease state, what we're looking for next. Has that been a discussion or maybe an evolution of what you started here from ECHO or stolen from GW? But essentially, has this ever been discussed, or is this like your next step that you'd like to see in the evolution of what you've developed at your site?
Yeah, thank you for the question. That is a real key piece of putting together the hub, is making it multidisciplinary and kind of shape for the primary care clinician or whoever is on the other end. Shaving off months in a patient's evaluation, all the people you would think about referring to, just bringing them all together. So having the nephrologist sitting at the table with us, maybe not every week, but on the weeks where because we'll get the cases a couple days ahead of time, and I'll do a quick review and like, hey, this is when we need our nephrologist to either come join us or maybe tune in from his office. The one that we've partnered with, he volunteers, or maybe this is what actually the behavioral health specialist we just have at the table every week, because diabetes is so heavy in kind of the psychosocial determinants of diabetes care. But yeah, that's a big piece, is having a kind of a multidisciplinary representation at the table. And so I could imagine for an oncology echo, you would want to have an endocrinologist on the panel.
personally been involved in. Kaiser looked at, for a certain medical center, looked in a year on those people who were the most admittable, so those who keep coming to the hospital over and over, and decided that they will take that specific group and create a panel around them that will involve all of the specialists, the primary care, social work, mental health providers, and other. These called care cases that were done by Zoom, and the patients a lot of time were at home, but they had the entire team that touched this patient coming on board once a month and intervene with those patients. And they reduced those admissions on those patients and complications with those patients and adherence to therapy by 90%. Just by getting the entire team together. So that's something that they start putting into practice. It's a regular thing now. They're doing it for patients who are the cost driver of the system. I know that they have done the same thing for oncology, for certain patients in oncology as well, especially those who were supposed to be doing better but were doing constantly worse, to see where are their failures are and able to bring in dermatologists, oncologists, different kind of aspects of the care. And we have been involved in that for now a good 5 years, and it's been going very well. That's one center that I know it does that. The other one, and now I know where I know you, is I was working for DaVita, and you had Bob White and others working with in Project ECHO in New Mexico, right? So I'm like, I know this guy from somewhere. Well, we were doing that for the nephrology patient, for patients who were failing home dialysis. Same thing. So we were looking at why are they failing home dialysis, and then bringing in the team around them, if you may, to kind of support them through the different interdisciplinary. But we always had the patients in, like what you were saying, Una. The patients were always part of that interdisciplinary team, because their involvement and their self-ability to kind of control and say what it is that they're failing was really important for the therapist to hear. So these are, I'm seeing those happening over and over, and they are kind of taking the ECHO model, but they're just using it for interdisciplinary approach in patient care, and great outcomes with that. And by the way, there's many great peer-reviewed articles about this that already been put out there, and I'd be more than happy to point them out to you about those kind of teams that have been coming. But I think they started off in ECHO and then kind of expanded to those interdisciplinary patient teams. Yeah.
I had a quick comment. I think I struggle with that concept in sort of my world of being a practicing oncologist and now working in a conglomerate of 27 different hospitals and many private oncologists, is that, you started out with a stated problem, and as did you, your dialysis patients that are feeling at home. I'm more aligned with Lee, where how do you get the physicians to even see that they have a problem in the provision of care that they're providing? That is really, where I'm in a large, very, very diverse healthcare system, and there's a very significant spread of expertise specifically to immuno-oncology. And even our, quote, worst performers are really unaware of their performance gaps. And so how do you get your worst players to the table? It's typically the highly motivated expert physicians who will be present in these tumor boards and present their cases. And we're reinventing the wheel every week again, right? Discussing the cases that we're already very good in managing, but the physicians who really don't have the expertise typically don't come. How do you motivate that? And how do you, to your point, Mark, right? If you don't design your goals correctly, right? A program like that, if I introduce that at my 27 hospital institution, and were to say I want to have an echo session every week for our immuno-oncology patients, I can tell you who's going to call in is myself and my partner, Dr. Richards, who, we see melanoma patients 5 days a week, but the physicians who see one a year who really would benefit from that education, and even if they only called in that particular Wednesday when that patient is in front of them, probably are not motivated. So how do you move the dial forward to, number one, identify the problem, make it that the physicians that are part of the problem identify themselves as beneficiaries, and then keep them aligned with that problem?
It's a great question. I don't know if anyone has looked at that extensively. One thing that some of the echoes, and we do as well, we'll do is look at the referrals that are coming in and use that as an opportunity to reach out to specific providers, and that could be your in. and say, hey, I've noticed you got this, you sent us this referral, our wait time is such and such, would you be interested in presenting this patient over the network in a de-identified fashion? But to more objectively identify providers that could probably benefit more is tricky. We've had discussions with someone in HRSA and the diabetes quality team about like maybe we could look across FQHCs and identify like centers in maybe where the A1C quality measures aren't in the top 75%. But then the question is, how do you motivate them to tune in? So if there's any ideas, there's a lot of interest in that.
We actually have a model, but no practical experience, so I don't know if it counts. But the idea of kind of becoming credentialed for a particular discipline. Our health system has bought hospitals throughout the state now, and there's a strong interest in, does your zip code affect the quality of your health care, right? And if you're seen at any of the systems, do you get the exact quality of care that you would get if you were at the main campus? Or let's be real, do you get better care in Western Kansas than you would at the main campus because of the challenges that we sometimes have in our delivery system? So one of the ways to do it is to make it, we're starting with breast and lung, and to make it such that there are enough of these sessions that you can go to and kind of check off that you've attended. And, it's really interesting. The administrators have as strong an interest in this right now as the faculty do, about trying to make sure that, again, that zip code issue isn't part of. And then the other piece of it is it lends credence to the quality of care that they're getting at our Hayes site, and that no, you don't have to drive to Kansas City. You can stay close to home and get just what you would get otherwise. So, and it's the ECHO model. So we'll see what the outcomes are. I can tell you right now, our biggest challenge is going to be not because we can require our faculty to all go in a really nice way, right? But I mean, you can do it, but it's a matter of giving them enough opportunities of the same session over again, because everything's going fine until 10 till 12, and then all heck breaks loose, and what you were planning on doing, it doesn't happen. So we're going to have this kind of rolling series of sessions to try to make it work. So.
I can tell you that I just seen incentives being done around credentialing is one way that I've seen this done, but I also seen it done around, straight out pay. I mean, I know that the Kaiser, for example, which can control the entire system, and their employee, the physician and their employees, not participating in sessions that were advantage to the patient, or not coming into this, being part of that ecosystem, was really adversely reflecting on them in their evaluations and other places. So they were creating some pressure points around this on purpose. I know the VA does something similar to that. It's really about forcing the hands a little bit of the physicians to participate, but to say, we looked at your outcomes over the year, in your case, they literally will look at physician outcomes, who are those physicians who have the most admitted patients, those who have the worst outcomes, whether it's diabetic or CHF or others, and they were forcing their hands to get those education, but giving them the opportunity to say, we're trying to educate you, help you, and get you to do better. And I think that they did it in a very nice way. And physicians were not to, I think physicians wants to do good, right? Provider wants to do good. So if you give them the opportunity, I think that they feel like this is in bettering themselves and their patients.
This is a very successful group model. I want to ask the two of you, is there an individual one-to-one model that has any reimbursement associated with it? In other words, is there a telehealth consult mechanism where an individual provider could call up a specialist or have an interaction where that time is compensated?
There are, and in particular, where CMS has been trying to, and CMMI have been trying to stimulate new kinds of practices like you're describing through the ACOs. There's a much broader range of reimbursements for that kind of synchronous one-to-one that can be staged in that context. It's much more restrictive, of course, when you're just dealing with general reimbursement via CMS, Medicaid, Medicare. But yes.
No, but in the remote zip codes, if you are in a rural community and you need to speak to a specialist who is in another academic or medical center, that's a reimbursable event for both sides, by the way, for both the presenting side and the receiving side.
One challenge is that
It's just not enough money.
Well, yes, that's one problem. And the other problem is CMS's mapping of what they constitute as an underserved region is kind of a mess. And for example, we know in areas of downtown Denver, there's and parts of Los Angeles for that matter, radically underserved populations, but CMS regards them as urban centers and none of those reimbursement programs apply. So, and there is actually this complicated mapping system where geographically you can find out where you can get reimbursement for some things or another, but it confounds even the most sophisticated billing departments to figure it out. So that needs to be improved.
Why don't we go ahead and move to a short break so we can reconvene at 10:25 and then we'll continue the conversation, talk a little bit more about the patient perspective. Thanks, everybody.
Perfect.